next speaker, we need to go ahead and get started. All right, so as I indicated, you have a full slide set of the concepts that were to be covered based on your workbook. We will invariably have little chance to completing all of those slides. So there are some concepts that are in there for your information that you'll have as you prepare for the exam, and that we won't have time to cover, just so you're aware of that. All right, so we're going to switch gears just a little bit and talk about study designs, that is the fundamentals of study design and interpretation. And then I would, based on my previous talks, say that the research topics piece of this, again, will be for your information, and the handout is sufficient relative to this. And I will be available for a short amount of time after, in the 10-minute break, to answer any questions. But I did want to say that you are welcome to contact me by email, and you can get that email address from the Purdue University website just by Googling my name. You feel free to contact me. I've had individuals contact me before with questions. I'm happy to try to answer those if I can. Okay. Same stuff. Learning objectives are obviously in your handout. So here's what we're going to talk about in the second half today, and that is introduction a little bit, talk about validity, bias, and confounding, some issues relative to clinical study designs, specifically observational and interventional trials, and then spend some time on clinical trials analysis and interpretation, summary measures of effect, and then you have some slides relative to research topics that we are unlikely to be able to get to. All right, so when we think about study designs, we think about some factors related to the things that are shown on this slide. And the first is, what's the purpose of this study? Is it a descriptive trial, or is it an analytical study? One that we're trying to simply describe, or one that we analyze and try to make some inferences about to other situations? What's the time orientation? Is it a prospective study in which we're looking ahead, or is it a retrospective study in which we're looking backwards? And I've listed these because there's a common misconception that, for example, case control study is the only type of retrospective study. Well, that's not the case. And we'll talk about some other examples of that. We'll talk about investigator orientation, and I've listed a couple of examples here. Interventional trials are the classic randomized controlled trial, or a quasi-experimental type design, which is an up-and-coming type of study design in the social and administrative sciences, which may not be fully randomized like a randomized controlled trial. And then lastly, and what we'll spend the most amount of time on, is what's the experimental setting? Is it a randomized controlled trial, or is it an observational trial? And what's the difference between those, and what are the differences in how we can apply those to our particular situations? So I've listed a hierarchy of study designs of what we're going to go through in just a second. But before we do that, we're going to cover some other smaller topics. But just recall that we'll talk about each of these. Okay, we'll finish towards the end with systematic reviews and meta-analyses. Okay, and we'll talk about each of these factors as we go through the remainder of this morning's presentation. But let's first start with some discussions of validity, bias, and confounding pretty quickly. All right, so when you're all gathered around a table at a journal club and you talk about the bits and pieces of a trial, you're talking about many of these factors. All right, so remember that internal validity assesses the validity within the confines of the study methods. Okay, does the study design adequately and appropriately test or measure what it says it does? Does the study adequately and appropriately address bias, confounding, and the measurement of endpoints? Does it talk about it? Is it open and transparent about what's being presented? On the other hand, external validity is basically, in a nutshell, can I apply these study findings to my situation? Okay, what about the study population is acceptable to me applying these endpoints to my situation? Okay, so internal versus external validity. Bias and confounding are somewhat related. Bias is the systematic, non-random variance in study methodology and conductance, okay, that introduces error in interpretation. A couple of examples, and there's some other examples in your handout, but perhaps a common type of bias is selection bias that arises from inappropriate selection of subjects. Okay, and we'll talk about some examples of that in the case control studies, and there are some others that are described that we'll also cover. Confounding, on the other hand, is a variable that impacts what we're measuring. All right, a variable that impacts the independent or dependent variable that alters our ability to figure out what really happened. Okay, and that could be either to hide an association or to make it look like there's a bigger association than we've actually observed. All right? So the best way to avoid confounding is, especially in retrospective or even prospective studies, is to collect all the information that we can, all right, in our data collection form, so that we're able to look at it during the analysis of this study, perhaps, and need to use some type of multivariate analysis in our analysis. All right, so let's go through the different types of clinical study designs, first starting with what really isn't a clinical study, so to speak, but first starting with case reports and case series. All right, so these are useful to document or describe experiences and novel treatments or somewhat unusual events. And it's kind of interesting, there are organizations now that are publishing guidelines similar to the Consort guidelines for clinical trials, methods for publishing case reports. All right? Such that investigators or clinicians are being transparent and forthcoming and reporting all the information that's necessary for reporting a case report. All right, remember a common example that I like to cite that was initially described by a case report was QT interval prolongation associated with the fluoroquinolone antibiotics, which is now a well-known toxicity of these agents that were first reported in multiple case reports followed by case series. We should recall that case reports and case series are hypothesis-generating reports. We're not testing hypotheses based on these, obviously. Case report, one patient. Case series, more than one patient with a similar experience. A common question that I get is IRB approval required for case reports? And my IRB suggests that individuals who are publishing case reports submit it for approval. All right, it's really quick, simple review, but this varies amongst institutions. Generally speaking, if you have a case series of more than one person, then that definitely needs to be submitted for review. All right, let's go through the three different types of observational study designs: case control, cohort, and cross-sectional study. And the overriding common theme of these three designs is that there's no intervention employed here, just observation. All right, which means that our conclusions investigate associations between agents or groups or whatever we're measuring, not causation. All right, and we'll come back to causation a little bit later and how we might assess that. All right, so case control studies first. So these studies determine the association between exposure and disease. And the classic example of this, whether you agree or disagree with the findings of this study, and for some of you it's way in your past, it's the association between aspirin use and Reye's syndrome in kids. These are often referred to as retrospective studies, and while they are retrospective, they're not the only type of retrospective studies. So ideally, we don't refer to them as retrospective studies, but we refer to them as case control studies. These are useful to study exposures in rare diseases or in conditions that take a long time to develop. All right, so critical assumptions that are required to minimize bias in these types of studies are, 1, cases that are chosen are selected to be representative of those who have the disease. And controls have to be as similar to those as possible, but obviously not have the disease. And the definition of these is crucial in the appropriate selection of those subjects. Okay, the other thing that's important is that the information that we collect is the same in cases and controls. That is, whether it's the same person, whether it's the same instrument that we're collecting information from, whatever, information needs to be collected in the same way. Well, the advantage is that these studies are relatively inexpensive and can be conducted pretty quickly. The disadvantage is that confounding in some way needs to be controlled for, either statistically or by assuring that our collection form collects the most and appropriate amount of information as possible. Now, sometimes we're stuck with the system that we're collecting information from, and we may not be able to get all the information that we have. Selection bias is often a problem with these types of studies, as is observational or recall bias, because we're often looking backwards, perhaps interviewing people, or perhaps collecting information from the past that's often difficult to assess. And the measure of association here is the odds ratio. Cohort studies are going to now incorporate time into these studies. All right, and our desire is to determine the association between exposures and disease development, again, over time. We estimate the risk of outcome, all right, and in this case now the measure of association is the relative risk, or often called the risk ratio. A classic example of a cohort study, a prospective cohort study, is the Framingham study, in which 5,000 people from a small town in New England were studied over time. Data were collected in those individuals, and then the incidence and natural history, in that case cardiovascular disease, was assessed in time sequence. Okay, again, that was a prospective cohort study. Well, there are retrospective cohort studies as well, and these are often referred to as historical cohorts. All right, and the study begins and ends in the present, but we're looking backward to collect the information and then following that up until the present time. Many of the advantages are like case control studies, okay, that these are less expensive, they're generally not time consuming. There's no loss to follow-up. All right, think about a prospective study. Think about a prospective cohort study. That Framingham study that was prospectively determined. Anytime somebody left Framingham, Massachusetts, they had to be called, or not email at the time, they had to be called or mailed to get information from these individuals. So retrospective cohorts are from the standpoint of loss to follow-up, much more efficient. but we're stuck with the same disadvantages as a case control study. The information we have is only as good as what we were able to collect, what was available from those individuals. All right, so the prospective or longitudinal cohort study measures things in the future. All right? Collecting data from those subjects whose outcomes lie in the future. Framingham, we collect data, individuals, we collect smoking data, we collect cholesterol data, we collect blood pressure data, and in the future, we investigate how many events happen. These are obviously incredibly expensive, all right, and incredibly time-consuming types of studies, much like a randomized controlled trial would be. They're also difficult to study rare conditions. That usually requires substantial amounts of time and much larger populations in order to do that. And then lastly, of the observational study designs, the easiest is a cross-sectional or a prevalence study, and that is a snapshot in time. We send out a survey to you, you respond today, we have all the data that we need to collect. All right? It's easy, data collected at one time, generally done by questionnaire interview or some other information. Now the disadvantage doesn't allow us to assess that over a time period. And it's also, unless we have incredibly large populations, difficult to study rare conditions. A couple of related concepts related to observational study designs is the concept of incidence and prevalence. They're defined on this slide as the incidence is the measure of the probability of developing a disease. The incidence rate would be the number of new cases of a disease that happen in a population in a specified amount of time. And typically these are represented in persons per year or person years. Prevalence, on the other hand, is the number of individuals who have a condition or a disease at any given time. All right? And a couple of related points are point prevalence, so the number of individuals who have a disease today. The number of individuals in period prevalence who have the disease in a year or in a month. All right, so incidence and prevalence, two somewhat related concepts that are often confused. Again, that are something that I would highly recommend that you look at again. All right, so let's look a little bit at interpreting relative risks and odds ratios, the two measures of association that are used in observational study designs. Remember, the key point here is for observational designs, this is not cause and effect, but it's association. So for cohort studies, as we discussed, the relative risk, okay, which means the same thing as the risk ratio, you should know that nomenclature as being one and the same, used for a cohort study. And then for an odds ratio, it would be a case control study, and that odds ratio is an estimate, ultimately, of the relative risk. So relative risk, cohort study, odds ratio, case control studies. So different from the interpretation of confidence intervals that we used in the previous talk, we evaluate relative risks and odds ratios on the basis of whether or not they're different from one. That is, when we have a relative risk and a 95% confidence interval for that relative risk, if that confidence interval includes one, then we would conclude that no statistical significant difference is observed. And we're going to look at many examples of this as we go through the remaining 55 minutes or so to ensure that at least you've seen this and can make some applications to this when you leave here. So let's look at the direction and the magnitude of an odds ratio and a relative risk and have some discussion or make some conclusions about what these things mean. So on the first table, on the upper half of this slide, describes how to interpret the direction of risk. So you have a relative risk and an odds ratio, and these two things mean slightly different things. So we're just going to focus on whether there's a negative association, no association, or a positive association between what we're trying to measure. So if the odds ratio or relative risk is less than 1, then we would conclude that there's a negative association at the factor that we're investigating. Okay, if it's exactly 1, then no association. And if it's greater than 1, that there's a positive association or an increase in the risk or increase in the odds. And then we assess the magnitude of that risk by actually looking at the relative risk or the odds ratio. So in the case of this relative risk that's 0.75, we would conclude that there's a 25% reduction in the risk that's associated with whatever we're investigating. Contrast that with a relative risk of 3, which would be a 3-fold increase in the risk associated with that particular situation. All right, so the direction of risk, magnitude of risk, again, highly testable concept. Given an odds ratio or a relative risk, and have to make some conclusions about what that actually means. So let's look at, again, a study, and the actual design of the study is not important. It's just the interpretation of what we see on a table taken from this particular study. So this is a case control study that investigated the impact of phenylpropanolamine and the development of stroke, okay, in individuals who use this agent as an appetite suppressant. Published greater than 15 years ago in the New England Journal of Medicine, but still a classic case control type of study. So if we look first, focus on really this column, that is the odds ratio column, that shows the 95% confidence intervals. Let's try to interpret, one, what does this point estimate mean? And by point estimate, I mean that odds ratio is the point estimate that's obtained in this particular study. All right, what does the confidence interval mean? This is a 95% confidence interval. And then lastly, which one of these are statistically significant? All right, so this point estimate of 16.6 means 16.6-fold increase in the risk of stroke in individuals who receive phenylpropanolamine. All right, large confidence interval, huge confidence interval. Because that confidence interval does not include 1, that's a statistically significant association. All right, 16.6-fold increase in odds, that was statistically significant. Down to this 15.9 point estimate, again, that's statistically significant. The second half of this, almost 2-fold increase, not statistically significant, pretty darn close, right, because that confidence interval includes 1. And the same is true for each of these other factors. Okay, so again, be able to look at that odds ratio, make some conclusions about a positive or a negative association, and then whether or not it's statistically significant or not. So for observational studies, just to highlight and remind you, I think questions, I know you can look at this book and there'll be questions about causation in case control studies. Remember, we're looking at observations, we're looking at associations, not causality. So what are some factors that may help us figure out and move forward in terms of whether or not there is some causality associated with this factor? Well, I'm not sure if bullet point 1 is very helpful, because if we observe a positive association and it's not statistically significant, well, we're probably not going to go any further. But what about the strength of the association? So the higher that odds ratio or relative risk, the more plausibility for causation, in my opinion anyways, exists in that case. The third bullet point, dose response. if we observe a dose-response effect, that is, as we observe these situations, if there's a dose-response relationship, then evaluating causality becomes a little bit more likely. Is the temporal relationship that exists typical of what we would expect when it happens? Have the results been shown before? Probably most importantly, is there biological plausibility to this association, or is it just we're just observing this because it's happening by chance? And then lastly, is there some other experimental evidence outside of the clinic in an animal or in an in vitro setting in a laboratory that suggests that similar findings have been found? Again, association, not causality for observational study designs. So there's a summary, and we're not going to go through this, but a review article. If you're interested in more information about this and have the time to peruse that paper, I would highly recommend it. Many of the concepts that we've discussed are highlighted in that paper. All right, so let's move on to interventional study design, randomized controlled trials. So these are studies in which we make an intervention and then evaluate cause and effect. We minimize biases in these types of studies through appropriate randomization or appropriate stratification as is necessary for that. The two most common types of randomized controlled designs are the so-called parallel design and the crossover design. So let's just look at these just a little bit in more detail. So crossover designs in which the same individual receives two or more therapies, okay, is a typical crossover design, and this is the most practical and statistically efficient design, as it minimizes the variability. Now, we don't have variability amongst individuals. The variability within an individual is much smaller. However, crossover designs are not always appropriate. And most clinical trials that we observe, long-term clinical trials, are parallel design. So the example that I frequently use is in a heart failure patient, that patient's disease worsens over time. So it's very difficult to do crossover designs in heart failure patients because their disease worsens from week to week, and often in 3 months their disease can be much, much different. So a crossover design is much more efficient in that case. So some examples of clinical trials, and again, these aren't earth-shattering, obviously comparison of two drugs or two behavioral modifications, but often we don't think about perhaps an educational intervention. If we randomize individuals to an online versus a in-lecture format, we can evaluate that intervention, or perhaps healthcare intervention, a pharmacist versus a non-pharmacist healthcare team, and the impact that has on a patient. So lots of different types of randomized controlled trials that you may be asked to make some decisions about. So some questions, and maybe these seem obvious to ask relative to randomized controlled trials. Are the results of the study valid? Do they make sense? What were the results? Can I apply these to my population? Can they help me care for my patients? And we're going to go through some of these questions relative to subgroup analyses, primary, composite, and surrogate endpoints, and some of the problems that exist in trying to interpret that literature. And then lastly, briefly talk about superiority, equivalence, and non-inferiority trials, which are, at least the latter two of which, are kind of exploding in the literature and often a little bit more difficult to interpret. All right, so let's talk about subgroup analyses first. And yesterday in the PEDS course, the individual who was given the statistics lecture talked about subgroup analyses, aka fishing expeditions. So hopefully that's not always the case, because I think subgroup analyses are an important part of controlled clinical trials, so long as they're designed or they're incorporated in the design of the study before the study is done and not necessarily after. They're obviously often overused and even more overinterpreted. So what are some potential pitfalls that happen with these kinds of studies? Well, one is, because by definition, this is not the primary endpoint, we're going to be making more comparisons or multiple comparisons, and we need to adjust our alpha value or our p-value as a result of that. All right, and there are statistical techniques that are done that we're not going to talk about, but they need to be incorporated in these kinds of studies. Again, because they're not the primary endpoint, and the study's not usually designed with subgroup analyses in mind relative to sample size and power, these things are going to suffer in the analysis portion of the trial. Well, of course, the primary endpoint is the most important decision that's made in the design process of a clinical trial. And if it's a study which is let's say, an indication approving study, then the FDA usually has some input into this primary endpoint decision. I want to read to you a statement from a important clinical trial from several years ago that shows sometimes the confusion that results when we use multiple composite endpoints. Ramipril reduces the rate of death, MI, stroke, revascularization, cardiac arrest, heart failure, complications related to diabetes, and new cases of diabetes in so-and-so. What the heck does that mean? Does it mean it reduces mortality? Does it mean it reduces the composite of all these things? Or does it reduce each individual endpoint? And that's what we need to know. The investigators need to be transparent in their reporting, and what we'd like to see is the rate of death reduced in a similar way to MI, to stroke, to revascularization, to cardiac arrest, or is one or two of these endpoints pulling the composite endpoint to one direction? All right, so there are some questions to ask. Was there a reduction in all the endpoints or just some? Are we actually seeing the forest plot that shows all the changes that happen? Are the outcomes just as likely to occur? And the next slide, we'll talk about some factors that may be being used now to help us with this. So why are composite endpoints important? Why are they used? They're used because they generally reduce sample size. They generally allow us to study fewer patients. All right? In order to adequately power a study, generally speaking, they allow us to use fewer patients. Well, here are some problems. They give us some challenges in interpretation. Okay? Many times we don't know if the negative results for one component also lead to or also associated with a negative result for another component. Something that frequently happens is the overall effect is kind of an average of the individual effects on each of the endpoints. Well, that's not ideal, right? We'd like all components, the benefits to be observed on each of the components of that composite. There has been some movement in the literature to weigh mortality endpoints more than perhaps symptomatology endpoints or other kinds of secondary endpoints. Ideally, we want to see the results of each individual endpoint so that we can evaluate each one. Surrogate endpoints present some different problems, and I want to highlight just a couple of surrogate endpoints and the potential importance to understanding what these things actually mean and how we use them in our interpretation of clinical trials. So we don't give blood pressure lowering medications to lower blood pressure, right? We give them to prevent stroke and mortality. We don't give LDL lowering agents to reduce LDL. We give them to reduce cardiovascular death. And the example here is we know that statins reduce LDL cholesterol very well, and they also reduce death. Well, we also know that hormone replacement therapy reduces LDL very well, but we also know that they do not reduce cardiovascular death in patients who have coronary heart disease. Okay, so two examples of things that we do to reduce surrogate outcomes that are beneficial. Contrasting that with, we can do a really good job of giving antiarrhythmic drug therapy to reduce ventricular arrhythmias by suppressing PVCs. But in doing that, we've shown on multiple occasions that this kills people. Okay, so we usually don't give antiarrhythmic drug therapy to suppress PVCs any longer because it's associated with an increase in mortality. All right, so that's an example of a surrogate endpoint that did not translate into a positive clinical outcome. So we have to be very careful in how we interpret these in terms of in our clinical trials, and not assume that these always are predictive of appropriate clinical outcomes. Other short duration studies that include these factors may not always be able to detect adverse effects that are associated with drugs, and we've certainly seen that in multiple situations. All right, we could spend a whole semester on superiority, equivalence, and non-inferiority trials, and unfortunately we're going to spend one slide. So you have for you in your packet, or at least in your reference section, a couple of papers that describe some of these concepts, and I will particularly attract you to or point you to a paper by Lever-Mullen in Pharmacotherapy a couple of years ago that talks about the hazards of non-inferiority trials and some of the impacts that they may have. So if you're interested, see that paper, and we'll talk about a non-inferiority trial here in a second, but it gives you some insight into what kinds of things can happen in those types of trials. So every year I mean to change this slide so it doesn't say the typical design in a clinical trial, because it's the classic design in a clinical trial, but it's almost not the typical design anymore. Superiority studies designed to detect the difference between treatments. Okay, the classic type of interventional randomized controlled trial. Equivalence trials are designed to confirm an absence of a meaningful difference between treatments or drugs. So, of course, pharmacists are well informed, or at least have been using these types of studies for a long time. Bioequivalence trials, generic versus brand, types of pharmacokinetic studies are equivalence trials. We don't often think of them that way. Designed, again, to confirm an absence of meaningful difference. Now, of course, the big decision that comes up in these types of trials is what difference is clinically important between the two therapies that we're trying to study. And that's the design decision that's essential. More commonly or being used more and more these days is the so-called non-inferiority design, which is a study designed to investigate whether a treatment is not clinically worse to some existing clinical study. Maybe the most effective or have a similar effect, and it's particularly useful when placebo-controlled trials are not able to be done due to ethical concerns. And we're going to look at one of these studies now. And the study that we're going to briefly look at is the On-Target trial, which was a study designed to investigate telmisartan, ramipril, or their combination in patients who have a high risk of the development of vascular disease. And the question in that study was, is telmisartan non-inferior in the development of cardiovascular death? Okay, and this was a comparison with ramipril studied in a previous trial that we'll talk about in a second. And in the design of that study, the non-inferiority difference that was defined as being clinically important was less than 13%. So what are the essentials, what are the important pieces of these types of design? And the first is that the control group, in this case, ramipril, must be effective in terms of the question that's being asked. Okay? That is, it's been studied and found in a previous study to reduce the incidence of cardiovascular deaths in this same situation. All right, so similar study, a previous study with control with equal doses. So we're using equal doses in this particular study as was used in the previous study. Clinical conditions are the same, and the ultimate design of the study is important. So this is where that Vermeulen paper that I talked about talks about sometimes the snowballing of these types of studies that happens as we get further and further and further away from the original study. In this case, the original study was the HOPE trial. So generally speaking, in these studies, power is a little bit higher than it is in other types of designs. And because of that, larger sample sizes are generally required in these types of study designs. All right, so let's go through a randomized controlled trial, go back to some statistical concepts, try to piece everything together relative to the evaluation and interpretation of randomized controlled trials. So I chose a classic, yes, I agree, it's old, a classic study that I think most of you have at least heard of or read or have had presented to you at some point in the past. But this is a randomized trial of estrogen replacement therapy for secondary prevention of CAD in women who are postmenopausal. And the overall question was, does this therapy alter the risk of CHD? All right, in these individuals. It was a randomized, blinded, placebo-controlled trial. You can see what the intervention was versus placebo in about 2,700 patients with CAD, less than 80 with a mean age of around 67 years of age. Follow-up averaged just over 4 years. 82% of patients still taking hormone replacement therapy at the end of 1 year, 75% at the end of 3. The endpoints, this was a combined endpoint, combined primary endpoint, non-fatal MI, coronary heart disease death, secondary endpoint, lots of secondary endpoints, but the most common was, or the most important was all-cause mortality. So in this case, the question comes up is, why not all-cause mortality as the primary endpoint? And the reason for that is it would have taken a long time with a lot of individuals studied for a long time to enable to use that as the primary endpoint. So non-fatal MI and CHD death was the primary endpoint in this study, in which power was calculated for, sample size, etc. The surrogate endpoint utilized in this study was LDL cholesterol lowering, and statistical analyses, the following statistical analyses were reported in this trial, and this is basically how they were reported in the study. Baseline characteristics were compared with either a t-test, no discussion of what type of t-test, okay, just a t-test, and a chi-square analysis. Power analysis and sample size calculations were performed, and the overall primary endpoint was compared Kaplan-Meier curves for survival analysis with a Cox proportional hazards modeling approach and intention to treat analysis. All right, so here's the baseline characteristics, and we've gone through some of these examples again, but we're going to go through them one more time because I think they're important for you to remember. All right, so estrogen replacement therapy, and I had a bunch of questions in between about how do we figure out paired versus unpaired types of t-test and analyses. So we'll make sure we hit that again. Since they didn't tell us what they actually used, I know what they used, but they didn't actually tell us. So we have a parallel design study in this case. All right, we have 2,700 some odd patients who were randomized to one of two therapies, either estrogen replacement therapy or placebo. Okay, randomized to these two groups, one of these two groups, and then studied for an average of, I think it was 4.1 years, or a median of 4.1 years. All right, so parallel design. So right away, this should come into your head that this is a independent samples t-test. These are two separate groups who are receiving two different therapies, okay, that are independent of one another. So independent samples or two-sample t-test, aka unpaired t-test. So those three things mean the same thing. Unpaired, independent, two samples. All right, so we're comparing between estrogen replacement therapy and placebo. I'm spending a little bit more time because there was probably 10 people who asked me this question at break. Clearly, I didn't do a very good job of explaining it. All right, so let's look at which of these baseline characteristics would we compare with a t-test versus chi-square analysis. So let's start with age. You can see here the mean and the standard deviation age in years. 67 years of age versus 67 years of age with a standard deviation of about 7. So someone asked me in the break, really good question. How do we know these data are normally distributed?